Imagine a country of 37 million people. It's 10 million square kilometers in area, and it has 10 major cities in which 90% of the population live. The remaining 10% of the population are scattered across this beautiful land. The median age is 39 years old, and for the first time ever in 2016, there are more people over the age of 65 than under 15. 25% of this population has one or more chronic disease. I invite you to close your eyes and imagine the healthcare system for this context. We have a below-average healthcare system. We are a poor performer when compared to our peer nations. And this ranking accounts for a variety of different aspects of our healthcare: safety, access, the outcomes that we achieve, and equity. Some further stats for you. 1 out of 18 hospitalizations in Canada result in a preventable, avoidable event that is harmful to a patient. 60% of Canadians report that when they're sick, they can't see a doctor within 24 hours. That's not great. Let's talk about costs. In 2017, we're expected to spend $242 billion on healthcare in Canada. And that's predicted to grow 3.9% over the coming year. Provincially, we spend 43% of our budget on healthcare, and that's expected to hit 50% within 3 years. I'm worried. This constant growth and this rapid pace of escalating costs, and there's an opportunity cost with that we're seeing spread through other social programs. We have one budget for all of our social programs, and as health continues to eat up more and more of it, other programs suffer. We have less for K-12 and post-secondary education. We have less for our universities. We have less for transportation and less for every other social program that we value. When Tommy Douglas started this in the late 1950s, the vision wasn't a mediocre healthcare system that put our other social programs at risk. How did we get here? Well, we've had about 50 years where we haven't had costs as a required variable in our decision-making. In addition, we have a fundamental design flaw in our healthcare system. We're narrow and deep. What that means is that when we go to the hospitals or when we see a doctor, Canadians don't have a copay. We don't pay anything for those services. And that's unique. There's only one other nation in the OECD that has that healthcare model. But that costs us breadth of services. Every other nation covers more services than we do. They include dentistry, they include services that are offered outside of a hospital, and importantly, they include medications or pharmaceuticals. Imagine Jane. Jane lives in Alberta. She's 62 years old, and she makes $50,000 a year. She has diabetes and hypertension, and she's on a usual mix of medication that's required to manage those conditions properly in the outpatient setting. If she can't take her drugs, she'll end up in the hospital in an acute hypoglycemic phase, which is dangerous for Jane, costly for the healthcare system, and unnecessary if she can take her medications at her home. In Alberta, because she's under 65, there are premiums for her to access the public drug plan, about $760 a year. In addition, she has a copayment every time she fills her prescriptions of $350-ish a year. In total, she has to pay $1,100 towards her prescription medicines that cost a total of $1,800. If Jane was over 65, the picture changes, and she would only have to pay $345 of the $1,800 required. If Jane had a different disease, so if she had cancer, or if she had an expensive disease and that had more expensive treatments, like for example arthritis, or a very high-cost drug for an infectious disease, she would have to pay $0. Does this make sense? I recognize that we can't pay for all drugs for all Albertans, but there has to be a better solution. Working with the government, we're simulating different design models that we could achieve within the same pharmaceutical budget that we currently allocate. We're working to understand the trade-offs that we would make. Who would gain more coverage and who would lose some coverage from the government if we redesigned this model? The end goal is to drive the number of Albertans who can't afford their medications from currently 1 in 10 to 0. I believe that everyone in the healthcare system is trying to do the best for the patient in front of them every day. Despite this, approximately 30% of our healthcare spending is on harmful, ineffective, or unnecessary care. What we know about health and healthcare and how best to help patients has changed a lot, and the system just can't keep up. Let me talk through some examples. Not so long ago, we used to think that opioids should be used as first-line treatment for pain management. Now we know that if there are other alternatives that can be used to manage someone's pain, they should be used first. And if you are going to use opioids, we should limit prescriptions to 7 days. In low back pain, we now know that imaging the back, unless there are other symptoms present, for low back pain, we don't need to do X-rays, CTs, or MRIs. And with antibiotics, we don't need to use those to manage the flu-like illnesses or a cough or a cold. They need to be used sparingly and for people who truly need them. When we look at different medical professional societies in Australia, the UK, and here at home in Canada, there is 1,700 of these kinds of practices that are added onto low-value care lists. This is care that does not provide good value for patients, for the system, and it's not a good use of our money. Working with the government, we can use routinely collected data to identify hotspots for this low-value care. We can then work with the clinicians and the people involved in the care and ask them what the issues are, what are the barriers that they face to providing high-value care. We can then design precise policy solutions to address the problem. And sometimes they're very varied. Sometimes it's that the financial incentives are misaligned for people to do the right thing. Sometimes the providers are simply unaware that the practices have changed and the standards are different than when they trained many years ago. Other times, it's a workflow problem, and we can redesign the process of care for the patient to achieve better outcomes. As we shift towards high-value care, that will free up resources in the system, allowing us to consider adopting and innovating with cutting-edge technology like that offered by precision medicine without increasing our budget. Moving forward, we're going to have some growing pains, and we have to make tough choices. Decisions will need to be guided by value. What are the greatest returns for our investments? Working with the system to incorporate value is something I'm deeply passionate about. We can use clinical, activity, and cost data that's, again, routinely collected within our healthcare system to plot all of the possible things we could do with new money or money that we're able to free up within the system on a simple cost-benefit grid. And what we'd be looking for is areas where we would have high benefit and low cost, or low benefit and low cost. But we could eliminate those areas that have low benefit and high cost. That's not where we want to spend our energy. Recognizing that there are many stakeholders within the healthcare system, we've come up with an innovative way to overlay a patient perspective onto this value lens. And when we do that, some of those dots move. Additionally, when healthcare is taking up 43% of the provincial budget, there is a political angle to healthcare. And so we can overlay a political lens onto our value calculations as well. And again, some more of those dots move. But what you'll notice is that there are some dots that remained high benefit and low cost, no matter which value lens you adopt. That's where we need to be focusing our energy in the immediate future to improve the value within our system tomorrow. We can't ignore this anymore, and promising more money is not the answer. We need strategic, precise use of our resources that are guided by value in our decisions. This is my life's work. How will I know when I can retire? When my kids and grandkids have a healthcare system that I know will be sustainable for them when they need it. When we have expanded to match the breadth of services that are offered in other OECD nations, and we have a healthcare system that can nimbly respond to the fast-changing world and integrate, when appropriate and in line with our value proposition, innovation and new technologies like precision medicine. This may seem impossible, but it can be done. Thank you.